All right. Well, thanks everyone for tuning in to and coming in person, especially to Grand Rounds at MGH. It is an honor to introduce Dr. Hauser. Steve Hauser, let me just warn you before I introduce you that I may have some of my facts wrong, but if it's a good exaggeration, just go with it. Dr. Hauser started off at MIT for college, at HMS for medical school, and then did neurology training here. And then I'm not sure where you did neuroimmunology training, but it might have been in France somewhere, here too, and in France. And then took his first job at Mass General. First lab was in the Warren building, Warren 3, right down the hall from pathology. And then started his career in neuroimmunology, publishing with Howard and the MS group here. Ultimately became one of the leaders in genetics, so found the linkage to HLA-DRB1, if I'm not mistaken. Okay. And then also identify the role of autoantibodies in MS and ultimately the role of B cells. And that's really where he's made his mark. He was the lead investigator on the rituximab trial. I think that was 2008-ish. And then ultimately Ocrevus, which is probably the most popular drug in MS, certainly in the Boston area. Probably 60–70% of our patients are on a drug that we have to thank Dr. Hauser for. So without further ado, and then, most importantly, moved to California, unfortunately, left MGH in the 90s, moved to California, was the chair at UCSF for 25 years, did a lot of the B-cell work there, and has now come back here to inform us about all of this and more. Please welcome Dr. Hauser.
Huge thanks, Michael, and thanks everybody for coming. Grand Rounds used to be on Thursday, but now it's on Wednesday. So the more things change, the more they stay the same, I guess. I'd like to speak about the past a little bit, because this is where my heart always comes. It's Mass General. The present and something about the future, and try to do it in enough time so that we have time for questions and answers. And thanks for everybody who's listening on the via Zoom. Well, when I was are there residents in the room? They're coming. Yeah, we were always late also. So in the 1970s, on the 11th floor was the neurology service. And every neurology service had a bathtub, and we had a clawfoot bathtub. And we would admit patients who had problems that we couldn't figure out. We would do diagnostics in-house. And if we suspected a patient of having MS, the staff would put the patient in a bathing suit. We'd examine the patient would go in a hot tub, and we'd examine them again. And if they were worse, we would say, well, this looks like, short-circuiting from demyelination and multiple sclerosis. We also had microscopes and centrifuges in the resident room. We looked at all the spinal fluid ourselves. We estimated the protein. We made sure that the red cells were not lysed, and it was a traumatic tap and not blood in the CSF. But we had to send the CSF out, of course, for the gold sol test and later the isoelectric focusing to look at oligoclonal bands, which are antibodies that are the products of clonally expanded B cells. And oligoclonal bands in the spinal fluid, but not in the serum, what we now would call a type 3 oligoclonal band, we would say was bingo. It was diagnostic for multiple sclerosis. We knew that that wasn't the case for any chronic inflammation had oligoclonal bands. But we were also all taught that these bands were diagnostic of MS, but were biologically totally unrelated to the pathogenesis of the disease. because MS was a pure T-cell mediated disease like rheumatoid arthritis. So overturning those concepts required bench to bedside investigations that would never have happened without many physician scientists who were really responsible for the rethinking of the pathogenesis of MS. There was a therapeutic nihilism also afoot, not at Mass General, but in many parts of the US community that don't even try to find a therapy for MS. It was a pre-therapeutic discipline for us in neuroimmunology. We had steroids, but that was it. And there was a general feeling that MS was likely to be a viral disease and not an immune-mediated disease, not an autoimmune disease. And if we would suppress the immune system of patients, we'd make them worse. Jacqueline Dupré, I don't know if any of you know who she, the senior people would know. She was a cellist beyond belief, married Daniel Berenbaum. Please, for the young people, take a look at a video of Jacqueline Dupré. Watch her playing the cello. She and the cello became one when she played. She sadly had a very typical course of MS. She developed MS in her late 20s, and 15 years later was bedbound and completely disabled. And that was the situation. So imagine an 18-year-old with a new onset of optic neuritis. The expectation was that on average, that person would be in a wheelchair at age 33. Clinical trials were also very different. When the first immunosuppression trial was done here at Mass General in the 1970s, there were 58 patients in the trial of cyclophosphamide. And boy, I knew every patient. I knew their families. I knew what they wanted, what they expected. When we finished the ocrelizumab trial, so everything was in these two spiral-bound books. With ocrelizumab, we had 9 million pages of data. And we needed to hire someone to carry the servers to the FDA from San Francisco. That is the change that has happened in our field. It's so hard to get our arms around clinical trials these days. So we've changed an awful lot since the days when I was in the back row here. But just think of all the good that we can now do for patients and all the good that we're going to be able to do in the next 5 to 10 years. Ray Adams would always hold court in the Ether Dome. We'd have grand rounds from 7 to 10 every Thursday morning. 7 o'clock were the neurosurgeons, 8 was a joint session, and 9 was neurology. And on Saturday mornings, we'd have brain cutting with Miller Fisher and E.P. Richardson. The neurology residents spent a year in neuropathology, our second year. And everything took place at the Ether Dome. Shirley Ray was there, but otherwise it looks just like it did here, even though this is a picture from the late 60s. It was all male, everyone well-dressed, everyone on time. So we've come so far. Can you see this arrow? In the old days, we knew that 9 out of 10 patients began with a course that was relapsing and remitting, and about 10% started with a pure progressive course, and that course called primary progressive MS would start about 10 years later than relapsing MS. We thought that MS had 2 phases, an inflammatory phase, lots of inflammation causing the attacks, The attacks here you can see as triangles. And then about 15 years later, defined imprecisely by severe difficulty walking to a bedbound state, we called progressive MS. And we said that was neurodegenerative. So there were two phases, inflammatory and neurodegenerative. And we knew that something was happening during the buildup, but we really knew very little about that. We also thought, I certainly thought, that all of the disease activity was happening about once every 9 months when people were having attacks. The MRI wasn't even a rumor when I was a resident. The residents would do pneumoencephalograms, carotid sticks. We would do angiograms, pneumoencephalograms, but we had no modern imaging. And modern imaging really revolutionized, when it came out in 1981, our understanding of MS. And we realized that there were bursts of multifocal inflammation occurring about 10 times more frequently than attacks. So there was a burst about every 6 weeks, even though attacks were only about once every 9 months. So you can understand how MRI not only gave us very important clues to the biology of MS, the importance of thinking of non-eloquent as well as eloquent regions of the brain, but also a much more sensitive marker, a biomarker that we could use for clinical trials. And the MRI enabled the modern clinical trial era in MS. I certainly thought, and I think most of us did, that if we ever had a treatment that could stop relapses in their tracks, the disease would stop. We didn't know if progression would start 15 years later, nonetheless. But that was our thinking and our hope. And we always would speak about treating MS like a cancer with induction therapy to turn off the disease. But we didn't know how to do it. What we learned, now that we can do it, as I think everyone in the audience knows, is that MS wasn't stopped. It was attenuated, relapses were stopped, but not disability progression. And disability progression marched more slowly, but it marched, but was previously obscured by the fluctuating neurologic status because of attacks, remissions, improvements. We've called this silent progression. It's also called in the literature PIRA, or progression independent of relapse activity. Silent progression is progression during the relapsing phase, and PIRA is throughout the disease course. But this led the community to a new thinking about MS, that inflammation and degeneration are present throughout the continuum of the disease. And of course, fighting PIRA is the elephant in the room. It's the unmet need that we have for our patients. If you look at the upper left here, we are also learning so much more about the premonitory phase of the disease. This has been a very important area in autoimmune medicine, autoimmunity medicine. Some of you may know of the teplizumab, a T-cell trial in type 1 diabetes that was published last year, where patients with 2 of the 3 diabetic serum autoantibodies, insulin receptor or GAD, who have a nuclear family member with type 1 diabetes were enrolled into the teplizumab trial, some as young as age 8. And they were able to show primary prevention of type 1 diabetes with pre-symptomatic treatment. And we also know, and I don't have time to go through all the data, that our understanding of human autoimmunity tells us very clearly that the beginnings in the premonitory phase are very focused responses, spread, become less benign over time. And that run-up in type 1 diabetes is about 9 months. In lupus, it's about 9 years. In rheumatoid arthritis with citrulline-aided antibodies, it's about 20 years. We've never had serum biomarkers that are predictive of MS. We know about radiologically isolated syndromes in patients of ours, who have a concussion and get an MRI and they have MS that seems to have been asymptomatic. We knew about that, but I'm very excited about new autoantibodies that are now understood to be a very specific biomarker for subsequent development of MS. Biomarkers against Epstein-Barr virus, which is the most important epidemiologic accompaniment of MS, and I'm sure Michael has given lectures about Epstein-Barr virus and MS, and in fact, an immune response to the BRRF2 lytic protein that is a biomarker that appears 5 years before MS begins. It's not sensitive. It's only present in 15% of patients, but it's absolutely specific. Also, a number of other related autoantibodies, including one for GlialCAM that Larry Steinman and Bill Robinson described last year. So we may be close to having serum autoantibodies that are predictive of future development of MS and may let us begin to think about treating disease even before it begins in some patients. As we all know, 30 years ago, in the early 1990s, the first generation of therapies, injectables, appeared. In the early 2000s, the oral therapies, and importantly, the first highly effective therapy, Tysabri, or natalizumab, that blocks lymphocyte trafficking. I'm showing this is a very personal view of efficacy versus safety. The first line of therapy were not very efficacious, but they were safe. The second line was more efficacious, but less safe. What we really want is something right here, up in the upper right-hand corner, something very effective and reasonably safe. Natalizumab, which became available in 2003, was rapidly taken off the market, as you may remember, because of cases of PML, an MGH disease in many respects, but could be brought back on the market 2 years later when a blood test for natalizumab became available that let us segregate patients at high risk and very low risk. So then natalizumab in low-risk patients, nearly half of our population becomes safe to use. And after many years, fortunately, PML with natalizumab hasn't been a canary predictive of more trouble down the line. Therapies that are much more aggressive, many of which are open label, came online throughout the last 20 years. They all have in common lack of safety. So I would argue that it's really been the B-cell therapies that has given us a class of therapies in the upper right-hand corner that we've searched for such a long period of time. And currently about 1 million people with MS are on B-cell therapy. This has resulted in a paradigm shift, whereas instead of going treating to target, starting with something less effective, and then advancing as patients break through, we begin by recommending first-line therapy in mostly all patients using highly effective drugs, which are B-cell therapies, or I think natalizumab in JCV-negative patients. I'd like to show you the data from ocrelizumab just to make the point of effectiveness. And the ofatumumab data is identical, similar to the rituximab and ublituximab data as well. The anti-CD20 ocrelizumab trials tested ocrelizumab against interferon high dose beta-1A interferon. There was a 2-year double-blind treatment. I'm showing you not the primary endpoint, but the number of enhancing lesions. And at baseline, there are nearly 2, about 1.8 enhancing lesions per patient on average. Interferon is effective. It reduces inflammation by about 75%. But it is reduced by more than 99% with ocrelizumab. This is an effect size that's been called unequaled in modern medical trials, with the exception of a couple of antibiotic trials that look similarly. That 99% effect size against focal brain inflammation with a B-cell specific therapeutic that very poorly crosses the blood-brain barrier tells us that B cells are at the center of action in MS, and also that MS relapses are beginning in the periphery. And it makes the point that we learn as much or more from the effects of our clinical experiments as we do from the laboratory work, but it's really when these two are brought together that accelerated progress is made. And then in the open label extension that is now 12 years out, one sees that all patients in both arms continue with ocrelizumab, and the safety profile is unchanged, even with 12 years of continuous therapy. And patients have fewer there's no need to get MRI scans in patients who are feeling well, who are on B-cell therapy, because they're always unchanged, unless we can get quantitative MRI metrics of progression. What about relapses? Well, relapses also come down, and they come down progressively. By a decade out, patients have less than 1 relapse per lifetime. But it's not down 99%. It's down about 50% compared with interferon. What are those relapses that are happening early on? Are they pseudo-relapses? Are they small so we can't see them? Are they in the spinal cord? Are they in the cortex regions that we're not imaging? Still, I think, a very interesting and open question. Now, the most important aspect of this, progression. What about progression during the relapsing phase of disease? Well, there's about a 40% effect size. So measured by the traditional scale, the EDSS scale, used to be called the Kurtzky scale. That's basically a measurement of walking at the higher disability levels. When we look at the EDSS scale, in patients not being treated or being treated with an ineffective or less effective medicine, about 6% of patients a year with relapsing MS will be worse at 1 year later. There's a 40% reduction down to about 4% per year, but it doesn't go down to 0. The other point, even in the open label extension where the interferon patients are moved to ocrelizumab 2 years later, 10 years after that, they haven't caught up. This is another feature of most of the modern clinical trials, that if you lose function early, you generally don't catch up. Let me show you the patients in an exploratory post hoc analysis who had the earliest disease, patients who had normal neurologic exams on admission, on a baseline, and on average had symptoms for about 7 months. This red line is the arm of those patients. So the effect size is even greater early on. Even a 2-year wait doesn't makes a huge difference in terms of progression. So earlier is better. What about the primary progressive MS trials? Well, that's less impressive. There's about a 30% effect size. And I think the secondary progressive MS data would also be about 30%. Is this clinically significant and worth it? I think the answer is yes. It translates to about more than 7 years of ambulation preservation over a lifetime on average. And again, no catch-up. Earlier is clearly better. Patients who have earlier progression clearly have a much higher risk of secondary progressive MS. The benefits of treatment, as you saw, are present even at the earliest stages of disease. And a whole encyclopedia of real-world data is now beginning to validate in long-term studies the importance or the advantages of high-efficacy therapy at the earliest onset of disease. These antibodies are not identical. Worth remembering that the murine antibody, of course, was the first antibody used against a T cell in patients. A chimeric antibody still has about 70% human protein, but 30% mouse protein. Humanized antibodies, about 90% human protein, and fully human antibodies are now possible. So these are very different stages, 3 stages in the development of monoclonal antibodies. Rituximab and ublituximab are chimeric antibodies. Rituximab was intended for B-cell cancers. That's why it was approved in 1997. And rituximab was never meant for chronic use. Also, for the most part, it's certainly in clinical trials, these have not been tested one against the other, and the dose finding has been pretty primitive prior to the trials. So are they the same? I'll show you that they're not in a moment. Don't we need our B cells? Why have these been so well tolerated? It's probably for 2 reasons. Fortuitously, the CD20 antigen is only expressed on the middle stages of the life cycle of B cells, from stem cells and pre and pro B cells to plasmablasts and plasma cells, which are the engines of antibody-making machinery. So plasmablasts and plasma cells that are responsible for our immune memory aren't touched by CD20 because they don't express CD20 on their surface. And pre and pro B cells similarly are CD20 negative. So one protects immunologic memory, the years of exposure to viruses and bacteria, and the vaccinations that we've had. And one also assures the repopulation of B cells. And I think that's a big part of the safety profile of these drugs. And the other is that, at least with a few doses, B cell depletion in secondary lymph nodes is only partial. And that's the yin and the yang. That's the safety, but it also may be why efficacy is less than we might like. CD19, I'll say a word about that a little later, does hit plasmablasts. It's also likely to be a little less safe than CD20. CD19 is one of the approved therapies, of course, for NMO. Well, how is this working? I said we thought that MS was a T-cell mediated disease. That was because of mouse EAE. It's had a wholly different pathology than human MS. It was Ray Adams who taught me that. We originally thought that autoantibodies were responsible. And when the FDA wouldn't let us give more than 1 dose of rituximab to people with MS, we thought we wouldn't see a positive response. because it would take a long time to winnow down antibodies. But what we found in the first rituximab trial was that the first MRI that was done just 4 weeks after the initial dose showed amelioration of disease activity. So it couldn't be autoantibodies that were responsible, at least not for the major feature of the disease. The genetic profile of MS risk falls heavily on B cells. And that risk, the variants that are associated with MS risk promote a pro-inflammatory phenotype by B cells, where they secrete more IL-6, more TNF, more lymphotoxin, and less protective IL-10. So maybe changes in cytokine secretion patterns and less bystander damage could be part of the story. Amit Bar has shown that really beautifully. Epstein-Barr virus, which is the most important epidemiologic link to MS. It is a powerful link and increasingly powerful and validated as a causal element in the MS cascade. Remember that we're all infected by Epstein-Barr virus. 60% of our B cells are Epstein-Barr virus positive if we have mono, but then they go away. But EBV lives in all of our B cells all of our bodies forever. It lives in about 1 per million or 1 per 100,000 B cells. So a very low reservoir, but it's living exclusively in our B cells and can activate B cells. And maybe Epstein-Barr virus is part of the story. And I'll show you how we think it might be in a moment. We now know that meningeal follicles, meningeal inflammation is such an important component of pathology, particularly with respect to progression. We didn't know that until about 10 years ago. We know that B cells are also turning on cells of the innate immune system, like microglia. I'll show you that in a moment. I think a big part of the story are changes in antigen presentation in people with MS. B cells, remember, express class 2 histocompatibility molecules and are professional antigen presenting cells. B cell here is in blue. Classically, it attaches antigens to its surface antibody receptor, surface antibody. It's digested, endosomally processed, and presented to T cells. And here you can see the red antigen on a T cell activating the T cell. Well, what we've learned over the past few years, and beautiful work by a number of investigators, has shown that one of the things that happens in people who are DRB1-1501, who have this MS gene, is that the HLA molecules of these B cells are not only presenting what their surface receptor is seeing, but they're presenting components of the internal proteomic environment. And one of the things that B cells are presenting in 1501 positive patients are digested peptides of the HLA molecules themselves. And that is stimulating a tonic T cell response. We've known for 50 years that people with MS, when you just put their cells in a test tube, they proliferate more than others, and that is probably due to self-preservation, self-presentation of HLA molecules on HLA molecules by B cells and not other antigen-presenting cells, activating a population of T cells, which then are cross-reactive to Akkermansia bacteria, to Epstein-Barr virus proteins, and to myelin proteins. So molecular mimicry may be enabled by this self-presentation of HLA antigens, and then with environmental exposures, one increases and expands the autoantigen response. So it's likely that B cell communication with T cells is really at the heart of why B-cell therapies are so effective certainly for relapsing disease. I'll just show you very quickly some new data that Gabriele Serono and Sergio Baronzini developed at UCSF using our electronic medical record, about 25 million records across the whole University of California system, extracting from the records patients who have MS, extracting those who are being treated with B-cell therapies for at least 2 years, and then using large language models to really extract all the clinical information from the records. And our cohort was the UCSF population, and we wanted to look at ocrelizumab, the more modern antibody, versus chimeric rituximab. We basically used propensity means to go back in time and do a clinical trial in situ, looking at the outcomes with ocrelizumab and rituximab. Bottom line, hospitalization rates at UCSF are twofold higher with rituximab-treated patients who are propensity matched for all risk factors you can think of. And then confirming in the other 5 UC medical centers, you see the same data, even a greater difference. And this was called to our attention during the COVID pandemic, where there was a clear problem with increased COVID severity in rituximab-treated patients, a signal that we didn't see with Ocrevus or with ofatumumab. And we now have ofatumumab data. Ofatumumab was not FDA approved until 4 years ago, so there's less data than for ocrelizumab. But the data looks identical. So this is hospitalizations. And as you can imagine, the hospitalizations are for infections. Look at immunoglobulin levels. I think everyone who treats with these drugs know that with rituximab, immunoglobulin levels tend to fall more than with ocrelizumab. And one sometimes gives IVIG to replete immunoglobulin in patients who have an infection on treatment. And what you can see is, again, that the decline in Ig levels is much steeper with rituximab than ocrelizumab, and once again, confirmed in the other 5 UC medical centers. And then let's just look at 24-week confirmed disability progression. And what was most stunning to me, we could only do this at UCSF, not at the other 5 centers. They don't record disability in a way that was as reliable, whereas we force it on ourselves to do it. The disability progression curves in relapsing MS patients were identical to what we had seen in the billion-dollar ocrelizumab trial. So for the young people involved, I think the use of AI and ML and databases can teach us so much, and we've not even begun to scratch the surface. For secondary progressive MS, we're seeing much steeper curves, and similar for primary progressive MS, with no real difference, but if anything, a slight improvement favoring ocrelizumab over rituximab, despite the more extensive depletion of immunoglobulin with rituximab. So let me just show you a case report of a patient who was also a friend who had MS for 17 years when we started rituximab. He was a captain of industry, and when we started rituximab, he was a competitive biker with an EDSS of 3, meaning his walking was normal. He had no further relapses. He was having a relapse about every 9 months. So that was wonderful. We declared victory and we toasted success. 2 years after starting, he said, "Doc, my right leg is worse. Couldn't see anything." But patients are often better neurologists than we are. He was right. And as you know, as you can imagine, it just kept progressing, rapidly progressive, secondary progressive MS, with death 2 years ago, despite 17 years of continuous CD20 treatment. He's a member of our deeply interrogated cohort. The immunologists might know of this cohort, the EPIC Origins cohort. Bruce Cree leads the cohort, and I would just point out that he was also homozygous for the only MS severity gene that we have been able to identify. I say we, it was Steve Saucer and Sergio Baronzini as part of the International MS Genetics Group, who are responsible for having found this gene that increases severity of MS. The other 233 variants that affect risk, but really have no effect on progression, on how MS behaves after it begins. But this variant, which is on chromosome 2 near the telomere, on the short arm of chromosome 2, near dysferlin and one of the zinc finger genes, clearly increases risk. And that's going to be a very interesting story. Only 2.5% of people with MS are homozygous for this variant, but this poor patient had it. And it's his last generous gift. He let us study his nervous system. He had a chronic active plaque that was responsible for his quadriplegia at C6. But I want to show you an amazing finding from his extensive neuropathologic investigation. We didn't find a B cell or a plasma cell anywhere in his brain or meninges. As expected, there was microglial proliferation, CD8 cytotoxic T cell infiltration, gliosis, but no B cells. Even in his spleen, look at that CD20, the second from the left at the bottom, no B cells. He was progressing in the absence of B cells. So when I think in this cartoon of the pathologies underlying MS progression, pathology 1 is the same pathology that underlies relapses in silent areas of the brain, or relatively silent. Our patients don't feel right? They tell us they have brain fog, they're fatigued, but we can't see it with our reflex hammer or tuning fork. But these focal areas of inflammation are one driver of progressive MS and the driver of relapsing MS. But there are at least 3 other pathologies. One, which is an old one that is well known, are chronic active plaques, slowly enlarging plaques, many of which now called paramagnetic rim lesions that have a layer of microglia at the leading edge and CD8 cells in the vicinity. I mentioned the meningeal aggregates that are B cell rich, and then a progressive gliosis with myelin pallor and CD8 infiltration in surrounding brain matter. So when we treat with CD20 therapy, at least over the long term, we can see B cells in 2 other cases where patients were treated for a year and 18 months. First presented by John Corboy. We've looked at that pathology again. So with short-term CD20 therapy, there's plenty of B cells still in the nervous system, but perhaps not with long-term. So what have we done with our treatment? We've removed the focal inflammation, and we've removed B cells from these other pathologies, but they're marching nonetheless. And I just want to make the point that the immunologists here know, which is that we're in pathology number 2, you can see the meningeal follicles. Wherever you see that, there is a demyelination and, importantly, neuronopathy in the lamina beneath and adjacent to these lesions. They're in the deep sulci where I think they're protected from the flow of CSF, and they are depositing toxic substances, cytokines, free radicals, maybe antibodies that are responsible for the neural degeneration. And it's these COX-2 positive lamina 2-3 cells that seem to be the most susceptible cell. The same cell that was recently found at the Allen Institute to be the most susceptible cell in Alzheimer's disease. So in the last couple of minutes, how can we do better? Well, I think most people in neurology have heard about the BTK inhibitors, the Bruton tyrosine kinase inhibitors. There's so much hope for the BTK inhibitors because maybe if we were to devise an ideal therapy for MS, it would target B cells and microglial cells. And that's what BTK inhibitors do. Bruton's tyrosine kinase is a member, of course, of the tyrosine kinase family. And there are 15 or 20 FDA-approved or in testing BTK inhibitors, 4 of which really are in late phase clinical trials for MS. The first was evobrutinib that looked fine in the phase 2 and totally flopped in the phase 3. Tolebrutinib, which looked good in the phase 2 and really a glass is half empty in the phase 3 with 30% effect against secondary progressive MS and an increase in inflammation at 6 months by MRI and relapsing MS. But I think the important thing about both of these drugs is that they're very non-selective inhibitors. For example, evobrutinib will inhibit 59 different tyrosine kinases. So I think the rubber will hit the road for the BTK inhibitors later this year and in 2026 when fenebrutinib and remibrutinib, a non-covalent and covalent, highly active, blood-brain barrier crossing, selective BTK inhibitor, now all in phase 3 clinical trials. When those are revealed, we will know the fenebrutinib data in primary progressive MS, tested against ocrelizumab, tested against the champion before Thanksgiving. And we will know the relapsing trial data. One trial will unblind before the end of the year and the other in early April, so we'll know soon. And then later in 2026, remibrutinib the data will be available also. So I think then we'll get a good picture. There's hepatotoxicity, especially with early dosing of these drugs, that seems to be a class effect. It's present even in the selective drugs, and it may be due to the targeting of Mueller cells in the liver. I don't think anybody really knows, but that is an issue that we'll have to deal with. What about CAR T therapy? Michael, have we been using CAR T at Mass General? There you are. Yeah. Great. Great. Well, CAR Ts have looked spectacular for some autoimmune diseases that were previously, untreatable. Lupus, scleroderma, some cases of myositis. And just a couple of published anecdotes and a few abstracts in people with MS. We've treated 2 patients, oligoclonal bands disappeared from the first, who had secondary progressive MS. But I think we'll have to see how this works. It's a huge undertaking. It's still dangerous. It requires conditioning with chemotherapy, hospitalization for infusion of the drug. So it is not an easy thing. This is certainly a transient technology that will be replaced by gene delivery to T cells of a CD19 or some other payload. And I'm very excited about BCMA targeted CD19s. BCMA, B-cell maturation antigen, looks to be even more effective in resetting the immune system, something that CD19 therapies don't clearly do. They don't change our immune repertoire the way BCMA does. But as also some of you know, parasites and some other endothelial cells may be CD19 positive. BCMA has even more reactivity in that regard, and the neurologic complications of these treatments will be something we'll have to pay close attention to. Obinutuzumab attaches a ferritin receptor, ferritin onto an antibody, facilitating not only crossing of the blood-brain barrier, but how the antibodies migrate within the nervous system. Alzheimer, multiple sclerosis, these ferritin shuttle antibodies, I think, are going to be a big story over the next year or so. We can target EBV, and I hope that we'll talk about this right after this talk. My own personal view is that we're going to be more successful targeting EBV in a primary prevention study rather than after MS has started and the immune response has diversified. But we won't know until we test it, and it's going to be a very interesting story. I also think that if there's a cross-reactive response that's triggering disease, we have to be very careful about vaccination strategies, that we don't turn on that response. And antivirals, as Dr. Levy has postulated, could be a much better approach if we were to try to eliminate the EBV reservoir. And again, multiple cell types are likely to be culprits, especially with chronic disease. But maybe if we treat early enough, we can mitigate that pathology and block progression. That's just a hypothesis. But it's fueled by the observation that with B-cell therapy, chronic active plaque enlargement is reduced by about 50%. So why would a B-cell therapy influence this microglial and maybe CD8-mediated pathology? Well, of course, it's through crosstalk between adaptive and innate immune system cells. So with that regard, the last thing that I'll show is a trial that Bruce Cree has led at UCSF, which is an impact trial where we are treating for 3 years with ocrelizumab at the onset of disease. I'll show you some preliminary data. All patients have been treated. There are 31 patients. It's a single study, a single hospital study. B cells, as we expect, are reduced by about 80% in the spinal fluid by 6 months and are undetectable at 3 years. And interestingly, in the CSF, the plasmablasts that remain at 6 months are only the late older plasmablasts. There is no migration of early plasmablasts from the bloodstream back to the CSF at 6 months at the dawn of MS. Here is immunoglobulin, CSF immunoglobulin. There's no change in serum immunoglobulin, but the IgG index is normalized in 13 of the 17 first patients 3 years out. And in some, oligoclonal bands are eliminated, as you can see in this 2276 patient, but not in other patients. They're attenuated a bit, but not eliminated. So maybe if we treat early enough, we can block not only what's on the surface, but what is below the surface during the silent progressive phase of relapsing MS. So I'll go very quickly. For those just beginning their careers, I think we have 2 great challenges. One is to begin to understand what criteria constitute a cure. And I would argue it's just like a cure with a B-cell leukemia. It's elimination of all symptomatic disease and all molecularly detectable disease. And if you have that, if you've reached that with B-cell leukemia and you maintain that off treatment for 3 years, you're effectively cured. There's a less than a 1% lifetime chance that the B-cell leukemia will reappear. So I think that's one huge opportunity and challenge with early induction therapy, and maybe even earlier. Can we turn the disease off completely? But I think the other next frontier that's very important is to move away from lifelong therapy. It's wonderful that there's no signal with 12 years of continuous therapy with an anti-B cell agent, but we don't want to treat patients for 60 years. And it's unlikely, I think, that it will continue to look benign at 60 years. So we need to have the rules of the road for when to stop treatment and when to monitor. And I think that this is going to be a very exciting area to have new paradigms for treatment, not only of MS, but for other chronic autoimmune diseases. So thank you all very much. It's a real honor to come back to my ancestral home.
Dr. Hauser, thanks again for coming. Thanks for showing how residents did work back then, and mostly thank you for all the work that you've done to transform our everyday MS clinics, right? We can see patients in a much easier fashion now that we're concentrating on how well they're doing versus in the past. You know, our waiting rooms were full of people in the wheelchairs. They're now running marathons and they're succeeding and living happily. Question is about the concept of benign MS. And I know there's a lot of a discussion about this, but back in the 90s and early 2000s, folks at Mayo Clinic showed that about 20%, probably much less than 20%, but we do see those patients in the clinic.
Yep.
And how much we can learn the biology of what keeps them doing so well, even without medicines.
I couldn't agree more. I think that studying extreme phenotypes is absolutely essential to sorting out MS, the most severe and the most benign. That's often done in genetics, but I think we need to do more of that clinically. The data is between 20 and 33%, and one could argue that it's even higher because as you know, the old pathology reports suggested that there's a high frequency of MS that may even be as prevalent as the disease itself in autopsy series in people who were apparently asymptomatic during life. So I think understanding benign MS is really important. And the only anchors that I have are two very old papers that show that 15 years out, people who have completely normal neurologic exams, completely, right? 2 millimeters of JPS they can feel in their great toes. If they are completely normal at 15 years, they're going to be well at 25 years. Those who have subtle neurologic exams, many of them get into trouble between 15 years and 25 years. So I think patients with normal neurologic exams, with few lesions, no spinal cord lesions, would be the group to consider as possibly more benign over time. But if it were me today, I think I would not want to take those risks. And except for the most benign presentations, I think that most people should be treated aggressively early on. Obviously, when patients have done well for a long time, we're not changing course. So I have many 70-year-olds on interferon and glatiramer acetate. So I don't change course if people have done well for decades. I'll make one more statement that is so similar to what you just said. Some of you may know Andy Josephson. I know he's spoken here before. He's my successor as chair of neurology. And Andy is the most energetic person I have ever met. He's absolutely spectacular. And he has built neurology enormously in the last 8 years at UCSF. And every division has grown, except our MS division. We have 27 practitioners in the division, but our patient census is about the same. it's so much easier. We're not getting called Friday evening because patients are having attacks. But general neurologists in the community and even general practitioners are comfortable now treating patients with MS with a once every 6-month therapy. And maybe that's really the purpose of the whole business, to put ourselves out of business. So I think that it sounds as if that might be the same experience that you have here.
So, Steve, if I can, having gotten the microphone early, wonderful again to follow that, to see the transition and realize that it's actually like 45 years since we crossed paths in the Anders building. But really, to your last point about not having lifelong treatment, do the studies include enough people who had to discontinue infusions for some other reason and were still able to be followed so that you can see the consequence? And perhaps there is a sweet spot where you need to get B cells down, keep them down, but in fact, you want to have them come back in order to sort of create a rebalanced immune system inside the brain.
I think that's a great question. One of the problems is that the treatments have been well tolerated enough that there are just a few patients. But I do think this kind of real world data on discontinuation should be amenable to study, because large population bases exist of patients like this who, because of an infusion reaction or something else, drop out.
Thanks so much. That was great. This may be an odd question, but I was always struck when I was a resident and earlier in my career by the range of patients with MS. You could see children with MS. You generally saw young adults presenting, but occasionally you saw what we used to call old folks MS, which, by the way, people thought was a relatively benign condition that was a pain in the neck, but not much to do about it.
Yeah.
So there's this massive age spread, and I suppose you can attribute that to some external stimulus, some environmental factor that someone happens to run into at the wrong time or the right time. But it gets also to the point of prevention. And you could say your treatments now are so successful, we don't need to think about prevention. If you get it, we'll take care of it. But is there a room for thinking about prevention or very, very early treatment? And what strategies would you think about, or is that a crazy idea because the disease is so treatable?
No, I think we need these risk biomarkers. To treat a disease like MS, we know that the BRRF2 antibody probably is there 5 to 6 years before MS begins. Epstein-Barr virus, on average, might be exposure 8 years before MS begins. I don't think that the world is ready for the kind of aggressive study that was done in diabetes with teplizumab or rheumatoid arthritis with rituximab. To try to prevent the disease in people who are seropositive but asymptomatic. But if we had an antiviral, I think that HLA matched or genetically similar nuclear family members, siblings of patients, could be a very tractable trial. Identical twins would be another group, but they're too rare. They're too rare. So the risk in an identical twin is about 25%. So if you're discordant, the risk in that healthy twin is 25%. In a sibling, it's about 3%, but it's much higher in siblings who have others in their family with MS and who are HLA identical to the sib who have MS. So that would be another trial that could be done. And in fact, the GEM study of pre-symptomatic MS that Phil DeJager, who used to be at the Brigham, has focused on, importantly, is considering HLA-matched siblings of people with disease. But again, I think we need something that we were pretty confident is safe, and we'd need a good outcome measure so that we could model how many patients we need to treat carefully. Yeah. And industry can't do a 10-year trial. It's just a 10-year blinded trial. It just won't work. That, I think real world data is going to have to give us some of it, but industry can do a 2-year trial. If you add a 3rd year, it doubles the cost of the trial. Isn't that amazing? And it's now $1.7 billion to do a trial. So we can't expect industry to take huge gambles or to ask how little of their drug can be used. That's not a fair thing to ask of them. So we have to do that.
Steve, thanks so much for a lovely talk, and congratulations on your Innovation Award in Life Sciences.
Thank you.
I wanted to ask whether we could conclude that patients with B-cell leukemias who were treated with some of these targeted drugs might have a different prevalence of MS than the rest of the population.
That is a great question. And we tried to ask that with Effie Petersdorf at the University of Washington, who has the largest bone marrow transplant population. She keeps the US registries, and it hasn't worked yet. But I think that's a great idea, Mike. And going back with AI and ML, let's try, that should be done. You know, the first case of mine as a resident, the first 2 cases, Mike was one of my mentors in those days and was just one of the residents, you know, a couple of years earlier. I don't remember if you were a fellow or you were junior faculty by then, I think. But there were 2 patients who I presented at Etherdome as a first-year resident. One was a patient of mine. I wrote about them both in a memoir that I wrote. One was a woman with MS who developed breast cancer, and her MS activity stopped. The second was a woman with sarcoid. And every time her sarcoid flared, she would tell me her MS got better, and vice versa. And those were the 2 cases that led to the cyclophosphamide trial in 1978. The idea that immune suppression could help people with MS. But I think your question about what about ceasing immune suppression and what happens, that's a great question.
Maybe one last one. This one comes from the website, the web group. It seems that PIRA can occur even with high efficacy therapies like targeting B cells. What do you think is the main pathological process underlying progression outside of relapses, and what could be potential treatments?
Yeah, I think it are those, the big ones are 2 of those 4 pathologies, the slowly enlarging lesions, and particularly those that have a microglial edge that cause more rapid T1 shortening and more destructive axonal damage within the plaques. And the second are these meningeal follicles. So I'm very excited about therapies that target microglia. One that is particularly exciting to me that's currently being tested in Alzheimer's disease is a monoclonal antibody against the inflammatory epitope of fibrinogen that protects against the clotting function, but that interferes with fibrinogen stimulating microglia. Those in the neurodegenerative field know that microglial targeted therapies like TREM2 have been a little bit disappointing, although it's still very early. And one of the problems is that we used to think that there was one type of microglia and then there were 2 types, M1 and M2. And now we know that there's enormous heterogeneity in microglia. So knowing what to target and not to target the good ones, but only the destructive ones, I think will be the key. The other big approach, I think, will be to target CD8 T cells. And amazingly, we don't have a CD8 T cell therapeutic in our armamentarium. Well, thanks, everybody, especially those remotely.